Thank you very much, Madam Cha. Assalamualaikum and a very good evening from Malaysia here, everyone. And also Selamat Hari Raya Aidilfitri to all my Muslim colleagues and friends. First of all, I would like to thank you, Dr. Alvin, and also Madam Cha, our friends from the Philippines, and from the Asia eHealth Information Network for the kind invitation. It is a truly pleasure to be part of the platform that brings together countries working together towards a shared vision. Today, I think I'll not just talk about the DRG, but I would like to step back and talk about something more fundamental, how data or sometimes the lack of it shapes whether our health system succeed or struggles. Now, back in Malaysia is we have in a critical juncture whether we are facing rising healthcare costs, increasing demand, and growing pressure across both the public and private sectors. So in this session, I'll share with you guys three things: why Malaysia is at this critical point in health financing, how case mix and DRG fit into our broader reform journey, and most importantly, what we have learned, not just the successes, but also the real challenges. Because ultimately, the value of this discussion is not just in what worked, but in what didn't, and what others in the region can learn from our experience. To understand a bit why Malaysia is moving towards DRG, we need to look at how our system is structured. So if you can see from the slides, we have a dual healthcare systems. The public sector is tax funded and provides highly subsidized care, while the private sector operates mainly on fee for service, funded by out-of-pocket payments and also insurance. As you can see from the slide, funding sources for public mostly is from local government taxation and even for government general revenue. And providers are multiple providers from multiple ministries, mostly from Ministry of Health, providing public hospitals and also clinics. They are also from Ministry of Higher Educations and also from our MINDEF. And for our private hospitals, they also provide services via private hospitals, clinics, laboratories, and community pharmacies. So from here, you can see the dichotomous system within the Malaysia, but all complement to each other and also provide services to our greater population coverage. Now, this sounds like a good balance, but in reality, it creates an imbalance. For example, public clinics make up only about 20% of the facilities, but handle around 64% of the outpatient services. You can see also most of our inpatient care, 70 to 75%, are burdened by backed by our public hospitals. So the public hospitals is heavily overloaded, while private services are more concentrated in urban areas. Because of this, patients face long waiting times in public facilities. Many turn to private care, even though it's expensive. So we end up with a system where access is not always equal and the financial burden can still be high. And importantly, we are using two different payment models. As I mentioned just now, budget based in public and fee for service in private. And this is exactly why payment reform, including DRG, become necessary. So now let's look at the financing challenge from another angle, not just how the system is structured, but how we are spending our resources. So Malaysia is facing a fundamental issue. We are not just under pressure, we are under investing. Malaysia's total health expenditure is about 4.7% of our GDP. To put that into perspective, upper middle income countries spend about 7.4%, high income countries spend about 8 to 9%. And within that, public health spending is only about 2.2% of the GDP. It means we are trying to deliver universal healthcare with significantly fewer resources than many comparable countries. But the issue is not only how much we spend, it is also how we spend it. Over the years, Malaysia has increasingly spent more on hospital care compared to primary care. From 1997 to 2020, hospital expenditure has grown much faster. Clinics and primary care spending has not kept pace. This creates imbalance because hospitals are the most expensive part of the system. So what happens is we spend more, but not always efficiently. And that's why reform is needed, not just to spend more, but to spend better. This is where the RG becomes important because it helps us understand and manage costs more systematically. Now let's talk about the real problem. Malaysia, like many other countries in this region, in Southeast Asia, is under increasing healthcare pressure, and this pressure coming from multiple directions at the same time. First, medical inflation. Healthcare costs in Malaysia are rising about 12 to 15% annually, which is among the highest in ASEAN countries. This is not just a number, it means treatment are becoming more expensive every year. New technologies are driving up costs and hospitals are facing increasing financial strain. Second, the private insurance premium. We are seeing significant increase in some of close to 20% in a single year. Now, what happens is when the insurance becomes more expensive, people will start to drop coverage and they will avoid seeking care at the private facilities. And eventually they will return to the public system. Which brings us to the third issue, the public sector is already carrying majority of the burden. Today, more than 70 to 70%, 75% of inpatient care in Malaysia is delivered by public hospitals. And yet our total health expenditure is still 5%, is still below 5% of the GDP. Now let's bring to the human level. When you see on the right corner, the numbers are talking about real people. Out-of-pocket spending in Malaysia is about 35% of total health expenditure. This means 1 in 3 ringgits spent on healthcare comes directly from patient. For many Malaysian families, especially middle income household, a single hospital admission can mean using up savings, delaying other essential expenses, or even taking on debt. That is why I would describe this as a healthcare pressure cooker. Everything is building up: cost pressure, demand pressure, system pressure. And if nothing changes, the system will not fail suddenly. It will gradually become unsustainable. So this brings us to the key question: why DRG? This is where many discussions become too technical. We're talking about groupers, we'll talk about classification, we're talking about costing. But today I want to simplify it. We try to describe the DRG often as a payment system, but I would argue something slightly different. DRG is not just payment system, it's a data system that enables payment reform. Why? Because for the RG to work, it depends on few critical foundation. Number one, accuracy of the clinical coding. Number two, standardization, classification, whether you use ICD-10, 11, ICHI, ICD-10, or other specific country classifications. Reliability on the costing data, consistency reporting across hospital via interoperability, and also governance and accountability. So with these elements, the RG will fail not because the model is wrong, but because the data is not strong enough. And this leads to my message today: no data standardization, no DRG, no interoperability, no trust. And when there's no trust, no reform. This is why there is just not a financing issue, it's a digital health issue and also a governance issue. Most importantly, every ringgit goes further, and for patients, it means fair access to care regardless of location. Whether you're in Kuala Lumpur or even Kota Kinabalu, patients should receive care that is comparable in quality and also reasonable in cost. I believe our Malaysian health financing system is like a patient with hypertension. At first, it looks manageable, maybe just a mild headache, but over time, if untreated, it leads to stroke. Malaysia healthcare financing is exactly that, a silent time bomb. Let me now show the Malaysia journey in developing case mix and DRG. This is where I want to emphasize that the DRG implementation is not a one-year project. is a long-term system transformation. As you can see from the left side of the figures, phase one, the foundation in 23 to 2006, we began the research collaboration between Ministry of Health, Ministry of Hospitals. At that time, the focus was to understand case mix concepts, clinical coding, costing methodology. Those are the learning phase. Then phase two is the pilot implementation in 2010. We launched the Malaysian DRG application piloted in 6 hospitals, Ministry of Health hospitals. And this is our first attempt to apply DRG grouping, collecting standardized clinical data and linking it to costing data. At this stage, we realized something important. The technical model is one thing, but implementation-wise is something else entirely different. Phase three, scaling up 2010 to 2023. Over the decade, we gradually expanded to all Ministry of Health hospital, which is about 149 hospitals in 2023. This gives us better coverage in terms of the data collection, greater visibility into the hospital activity, and also insight into the cooperation between the hospitals. In 2024, 2025, we upgraded our application Malaysian DRG to another system, what we call MyCMX, and this application is also integrated with ICD-11. This is crucial because we are trying to move to a more international standards, improve in terms of our data comparability, interoperability, and also future integration with other systems. So now, where we are, Malaysia is moving towards a more unified national DRG system, not just within Ministry of Hospitals, not within the Ministry of Health hospitals, but with the wish to across public sector, which is our counterparts in university hospitals and military hospitals, and eventually with the private sector. Even after 20 years, we are still on the journey because implementing the DRG at national level requires more than just a system, not just a grouper, but also a policy. It requires strong governance, standardization of the data, capacity building, and alignment across all stakeholders. So the key takeaways from this journey, I would like to say that DRG is not about quick wins. It is about building a system step by step and learning how to go along the way. So if you can see here will be our clinical data requirements. They will be categorized into DRG purpose and also administrative purposes. Most are mandatory because it is related to logic indicator or even the RG driver. I'm sorry, the demographic data, actually the sex, age, and birth weight will be categorized into mandatory category. And we also have other encounter data, length of stays, departments, and so on. In terms of our clinical data, our diagnosis are coded using ICD-11 for most of the Ministry of Health hospitals, and our procedures are coded using ICD-9CM. But we would like also to implement another classification once the WHO give us the green light, which is the International Classification of Health Interventions. The rest will be on other administrative purposes like patient's name, IC, admission date, discharge date, and even we would like to have other patient level costing data, which is that in terms of expensive and advanced treatment like drugs, imaging, procedures, and so on. This would be our costing data template. And you can see most of the costing is comparable with other countries. Bed occupancy rate, average length of stay, turnover rate for patients, inpatient days, patient visits to the clinics, daycare visits, and so on. This is based on performance metrics. In terms of staffing, we would like to understand what are the distribution of people of our human resource in the hospitals. Facility structure, we need to understand what are the strength of our beds, actual beds, critical beds in the hospitals, and the most important thing, our financial or expenditure data. We would like to understand on the total health expenditure to operate the hospitals, whether is it operational or non-operational data, total salary, or even professional fees for our specialists, land and building value, and some will be on the revenue, the financing cost, and also the taxation. This is just the basic data that we want to calculate using hospital data, expenditure data to calculate the hospital base rate. But we would like also to calculate based on departmental data. We have not moved to patient level costing data yet, but I believe other countries also moving in to calculate much more detailed or granular data as much as possible. I would like to mention that in Malaysia, we have not used DRG yet for payment system. We use it for quality monitoring and to understand our uh, hospital activity or even severity of illness of cases in the hospital. So in Malaysia, as I mentioned just now, fee for service for public hospital is still tax funded and private hospital is still mostly out of pocket and some will be from private insurance. So what worked in Malaysia journey, you can see from the slides before, there are three key things that I think I can highlight here. First is the strong policy intent. There is clear recognition that fee for service is not sustainable and the RG is seen as part of the solution. Second, nationwide implementation, case has been rolled out across all MOH hospitals and some in the university hospitals, and this gives us a scale and better visibility of the data. And third, growing cost awareness. Hospitals are now starting to ask a very important questions. Usually they don't ask this, but they now do. What does a case actually cost them? So due to the hospitals are patients are heavily subsidized, hospitals are given global budget based on historical. So now they are start asking us what are the actual costs to deliver the services. So this is a big shift from focusing on volume to focusing on value. At the same time, this is not just an MOH effort. We are working with large ecosystem, the public, the private, and the insurers, and bringing everyone together, both and the challenges and strength. But let me move to the more important part of the story. Not that all things work, but what didn't, because in reality, this is where the real learning is. The first challenge is data quality. Not all hospitals code in the same way. Public hospitals, most of the public hospitals code diagnosis using ICD-11, but there are some HIS or even digital hospitals are still using ICD-10. The private hospitals, we use some other classifications. I'll show you later on some of the classification that we have in Malaysia. So you can see from here, the same procedure information can be coded differently across public and private hospitals. So the issue is not just coding, the issue is consistency and discipline in data. The second challenge is capacity. We simply do not have enough trained coders. We don't have enough skilled health information professionals. And equally important, our clinicians are not always fully engaged in coding. In reality, coding is the foundation of financing. If coding is weak, DRG will not work properly. The third issue is fragmentation. Different hospitals are using different IT systems, different data structures, different workflows. And if integration between this system is totally limited, so even if the data exists, it's not always connected, it's not always comparable, it's not always usable at national level. So this brings us to the biggest issue, interoperability, especially between public sector, private hospitals, insurers. So public hospital have different data set, private have another, insurers have their own data set. The system just do not talk to each other effectively. And to be honest, technology was not our biggest problem, actually. The governance and data discipline were, we had systems, we had platforms, but we do not always have standardization, accountability, interoperability. So you can see from these slides will be the classification used for the public hospital and private hospitals, where you can see from diagnosis, Ministry of Health using ICD-11 and some are still using ICD-10. There are private hospitals that are using clinical classification software refined or even chronic condition indicator refined. There are procedures where multiple classification are used for different purposes like quality monitoring and also charges. In public hospitals, we are using ICD-9 CM for procedure coding. We hope that we can use ICHI or International Classification of Health Information in the nearest time. The other private hospitals, they use different classification like Malaysia Medical Association, medical procedures, current procedural terminology, CPT, and clinical coding and schedule, development schedule. There are also others coding for drugs and so other supply and services that can be used, but it's not standard between the hospitals. You can see from the side, let me highlight that I believe it's one of the most critical issues, not just for Malaysia, but for many countries in this region. We are not lacking system, as I mentioned just now, we are lacking connected systems. Even after 20 years of working on case mix and DRG, we came to a very simple but uncomfortable conclusion where the DRG is fundamental a data-driven system. And in a data-driven system, data is power, but only if it is reliable. Otherwise, garbage in, garbage out. Today, Malaysia has multiple health systems across different sectors. As mentioned just now, public hospital use different cluster structure, private hospital using another, insurers using and maintain their own platform. And each system works on its own, but the problem is these systems do not fully talk to each other. And this creates three major challenges. Data silo. Data is fragmented across institutions. Example, a patient may receive treatment in a public hospital, follow up in a private clinic, and then be covered by insurance or even out-of-pocket patient, but these data points are not integrated. We cannot see the full patient journey, the continuity of care, and also the true cost across the system. Because data is not connected and then costs are not easily comparable between each provider or even the services that being rendered. The pricing structures vary across the providers and payment decisions are not always evidence-based. For instance, two hospitals may treat the same condition, but if you see the comparison between the cost and resource utilization, I think it will be quite hard when the data or even the data set are different between the providers. Without interoperability, the cost transparency become very difficult to achieve. And this leads directly to inefficiency in financing. If DRG later will be used for payment, it will be hard for the payers to align in terms of reimbursement. The providers will be paid differently for similar services if it's not standard. And maybe we cannot achieve or we cannot pay incentive based on our initiative because everything is remain fragmented. Even if we introduce DRG without interoperability, the system cannot function optimally. That's why now we're moving towards a more unified or more central national DRG system to harmonize data standards, to align payment mechanism, and also to enable interoperability across sectors. Interoperability is not a technical feature, it is a system requirement to reform. So this next slide shows the moving forward or the future on DRG. Where do we go from now? Malaysia is now entering the next phase to reform. It's beyond MOH towards a whole of system approach. We are now exploring and expanding the DRG into the private sector. This is a major shift because until now, most of our efforts has focused on mostly our public hospital, Ministry of Health, and also some of the university hospitals. But the real challenge and opportunity lies at the public-private interface or integration. because healthcare delivery in Malaysia is not a single system, it's a mixed ecosystem between multiple providers. And if these parts are not aligned, the reform will always be incomplete. That is where some of the initiatives like medical and health insurance takaful become important. The idea behind the MHIT is to create a more standardized based insurance product and that is affordable, transparent, and also sustainable. And importantly, it is designed to support value-based healthcare. Through MHIT, we aim to improve financial protection for our Malaysians, reduce out-of-pocket burdens was 35%, if you can see from the previous slides, and also to strengthen the confidence in our private providers. But most importantly, it creates a platform where payment models like DRG can be applied more consistently. So this is the research initiative. You can see there are 5 strategic trusts. There are 11 initiatives and all are focusing to multiple objectives to be answered. The one in the red color, you can see there are product, the base MHIT, the insurance takaful product to support the value-based healthcare. This is one of the initiatives. The blue color number 11, you can see to establish standards and mechanism for data collection on private healthcare costs. And the orange box, the phase implementation of DRG to replace fee for service as a provider payment mechanism. So these all initiatives are used for multiple other strategic objectives. This is why governance frameworks becomes critical. KISMI is often seen as too technical or even IT project, but in reality, it's a policy and governance reforms specific to financing because it requires alignment across institutions, public and private, enforcement of the standards, continuity monitoring, and also audit. There are another important insight where you can see payment models shape behavior. So once we move from fee for service to DRG, you can see the changes of behavior, whether intended or unintended. This provider payment mechanism or PPM influence in terms of clinical decision making, resource utilization, and also patient pathway or clinical pathway. For example, fee for service encourage volume. You can use it for purchasing each vaccines for our public patients. There are budget-based system may limit efficiency incentive, like the one that we have currently. And we also, there are other provider like DRG that encourage cost awareness and also standardizations. So the DRG is not just about payment, it's about shaping how the system behave or even where the system behave according to a provider payment mechanism. To summarize the transformation that we are trying to achieve, we are moving from paying for volume to paying for value. We are also moving from fragmented data to a more integrated and standardized systems. We are moving from passive reimbursement or passive financing to a more strategic financing. So this is just not a technical shift, it is a fundamental change in how the systems operates or system works. Because ultimately, the RG alone cannot fix the systems, not the silver bullet for everything. The insurance reform alone cannot fix our health system, and digital health alone cannot fix in terms of data collection and integrity. But together, we create the foundation for a more sustainable, fair, and efficient healthcare system. So let me conclude by sharing some practical lessons from Malaysian journey, especially for our colleagues across the region, like from the Philippines, I can see others from, mostly are from Malaysia, where we can explore or others can adopt on similar reforms. These are not just theoretical lessons, but they are based on what we have experienced for the past 20 years, including what worked and what didn't. The first lesson is start with data, not payment. There is often pressure to move quickly into payment reform, tariff setting, or price setting, or even reimbursement models. But without strong foundation in clinical coding, classification systems, standardization of data, payment reform will not be sustainable. In simple terms, if the data is weak, the payment system will fail. Second, standardization must come before scaling. It is very important or even tempting to go nationwide quickly, but if definitions differ between providers, coding varies, systems inconsistent, then scaling will only amplify the problem. We learned that it is better to move slower but with consistency than to scale quickly with weak standards. The third one, governance matters more than software. I believe many countries adopt and adapt from existing DRG grouper or data collection platform. They try to choose the right system, whether is it okay or suitable for their country, and most of them procure a technology that have been used or been experienced in other countries. But in reality, technology is the easier part. The harder part is the policy alignment. We can see in terms of the multiple standards being used to enforce them to use a much more generalized or even unified standard will be hard for us. And also in terms of the accountability of the data quality. Without governance, the best system will not deliver results. The fourth one, avoid big bang implementation. The RG is complex. It involves clinical practice. It involves data systems. It involves financing mechanism. So instead of rolling out everything at once, start small, pilot, learn from mistakes, and refine. Because in reality, the first version will never be perfect. We had developed for the past 10 years, we had developed our DRG for three versions, and we are also trying to make a new one in our national DRG. Finally, engage the private sector early. This is one of our biggest lessons because if the DRG is developed only within the public sector, integration later become much more difficult. It's hard for us to integrate between the public hospital and the private hospitals, integration between hospitals and clinics, integration between the health providers and the community. Everything is not as easy as it is. The private providers, insurance, and payers must be part of the conversation from the beginning because ultimately healthcare systems are shared ecosystems. It's not isolated sectors. So let me end with this. DRG is not perfect. No system is. But the real question is, can we afford to continue without reform? With rising costs, increasing demand, and pressure on both patient and the system, the answer is definitely no. DRG is not a complete solution, but it's an important step forward because it's not just about payment, it's about data, trust, governance, and ultimately it's fairness. And I believe if we get the data right, we can get the system right. I'm happy to take any questions. Thank you very much.
Thank you very much, Dr. Fawzi. For the first question, we can read the question from Dr. Alvin. So thank you, Dr. Fawzi. It is good to learn from the Malaysian experience. Will the DRG be optional for the private sector or will they also be compelled to use DRG?
So if you can see from the slides, the research initiative was started back 2 years ago, and to implement the DRG for the base MHIT product or the Malaysian medical health insurance and travel and also Takaful. We would like to do it voluntarily first. Most of the patients are volunteer to be involved in the insurance product. and we would like some data, and also costing data from the private hospitals to be collected. So based on the public hospitals and the private hospitals, so we know that there are um, standardization in terms of clinical pathway. There are also we can see the difference between the costing of public and private providers. So if the idea is to standardize all providers using the same standards, then hopefully we can use the DRG for provider payment mechanism for the whole country.
Thank you, Dr. Fauzi. We have another question here. It's from Dr. Shamala Gopal. So, hi, Dr. Fauzi. Given that many countries undertook prolonged governance and readiness assessments before adopting DRG, how would you characterize Malaysia's position and pace in pursuing DRG implementation?
So we received this how can I say this remarks from our counterparts whether we are moving too slow or we are not progressing fast enough. But we did learn this from other countries. You can see not just from European like Germans, Slovenia, or even our Nordic countries. ASEAN countries, you can see like Indonesia, Thailand, they grow uh, each and every time they revise their version. It's not the first version will never be the best version. So they will take some time to progress and mature. And even our colleagues from World Bank also mentioned that don't go too fast to adopt to make everything complete. Uh, you need to learn because every country experience differently. Uh, we know that for Malaysia, there are few things that we need to align in terms of data collection, sharing the data, sharing the even their costing data. But with the right objective, I believe this is where we can start now, so we can benefit in years time.
Regarding standardization, who is the designated authority to engage the stakeholders and encourage them to adopt them?
So in Malaysia, we have Health Informatics Center. So in Ministry of Health, they govern in terms of standards that can be used, such as clinical classification, ICD-11, ICD-9 for procedures, and later if the WHO permits, we can use EG. We know there are also other standards like for pharmacy, drugs, and so on. For billing purposes, private providers, there will be from our medical practice division that actually depends on the private act. There are bill mm, we call it Schedule 13 for each and procedure cost or even tariff that need to be they need to use for the patient to pay or for to deliver the services. There are also, if you talk about technology, we have our health mm, digital health office that actually decides the future on standardization or not just standardization but interoperability between the systems and whether the platform are using Fire 7 or even any other standards that can be used. So the depends on which standardization I'm talking about.
Our next question is from Dr. Azreen Ahmad. So, if it's a specialized institution like rehab, will DRG come as a problem as a diagnosis is considered a continuation rather than primary diagnosis, hence the weightage be less?
So if in Malaysia, we do collect data from all type of hospitals, including our rehab centers. We do have other rehab centers from Pekeso, but they will be slightly different. In other countries, there are cases where the payment using the DRG they include and also they can also exclude those rehab cases. But before we decide on such policy, we would like there's such data. This is more like chronic cases, not just rehab, but like palliative care or even rehab, palliative, psychiatric, mental illness, and so on. So those kind of cases would be very unique. You need to look into the data differently. And again, some country pays those cases and some countries exclude and pay them by fee for service. So it's just country policy whether uh, to use or to whether we pay those patients according to the DRG. But in terms of the diagnosis, data collection, it will be mostly the same. Maybe there are some parameters we need to have to differentiate between the acute and chronic case. Uh, that will be still under discussion within our technical advisory committee.
Our next question is from Dr. Zairine Zamvi. Can you share with us the operational challenges with regards to DRG implementation within our region for the countries who have adopted and adapted DRG?
So most of the time, when the country starts using the RG, there are a lot of hiccups. I call it hiccups. There will be intended and unintended system behavior changes. Most of the countries, no, sorry, most of the providers would like to profit from this new payment. The intended, the unintended, I'll talk about unintended consequences. Most provider will try to game the system in terms of service delivery, shorter length of stay, higher readmission rates, team scheming, try to choose more profitable case compared to more complex cases, push away all the complex cases to public and just keep all the simple cases. Even the RG clip where you try to code those kind of cases complex, even though it's just a simple procedures. So those are the first uh, system behavior changes that you can see. But in terms of, I believe, the guidance from our insurance in Malaysia, the claims, the medical necessity, what kind of cases to be included inside the benefit package, what are the cases need to be included, excluded, or even what if there are innovative procedure or even high expensive drugs or even robotic can be used within the DRG. So those kind of questions is actually we have discussed it within our technical advisory committee, and there are ideas whether we can include those cost structure or cost item within our price or tariff setting, or we can exclude it as our unbundling factors, or even we can pay it using other payment mechanism like fee for service if it depends on the objective. So there will be other things that the challenges for each and country to when they start to implement the RG. I can share on Malaysia public hospitals, the data quality. You can see the difference between the completeness and the accuracy of the clinical data, and you can see the awareness from the provider in terms of to learn on what are the costs to deliver the service in the hospital. I believe later our private hospital will also like to learn whether their services are close enough or even much more better efficiently compared to the tariff or even price setting that we will calculate within the MT.
Our next question is from Dr. Chikun Chan. So could you please comment on the major differences, operational challenges or built-in incentives between implementing DRGs in the Malaysian public sector versus in the private sector?
I believe this is a more system challenges. In my slides, I shared that our public hospitals are much more tax funded base, and patients or even our rakyat is heavily subsidized. If you go to our wards, inpatient wards, when patient discharge, most of them pay 99% from what the charges for the services that rendered. That would be from public facility. But for private, they are much more driven by mostly volume because of the fee for service payment mechanism. So those first thing will be the major difference when you want to start using the RG, because the idea is to have a more fair, standardized, and also comparable between the provider with providing the same services. Uh, Need to understand on the incentive to provide the country policy. If you want to push for, let's say, certain procedure to be embarked on, like let's say you want laparoscopic, then whether you set the parameter or you set the price, the laparoscopic procedure to be almost lucrative or almost as similar when you do open market procedures. So those kind of things that you need to understand from when you decide the benefit package and when you decide on the price setting. Uh, Not much on Malaysia because we have not used the LG for payment yet, but I believe other countries, when they start using it, there will be some challenges on the provider trying to, like I mentioned just now, gaming the systems, the unintended consequences when we start using the DRG. So if I can answer that simply, is just the finance system you need to change in terms of the public and private, because those are the big things in Malaysia.
Our next question is from Dr. Aisha Ayman. Based on regional experiences, which areas of DRG implementation tend to generate the most disputes or clarification requests between hospitals and payers?
I'm not sure on other countries, but we did discuss this outliers cases compared to the one within the inliers, the DRG. I did mention just now whether we need to unbundle cases with expensive drugs, advanced procedures, implants. Those kind of cases will be much more dispute, because whether we can consider it as a basic services, or is it a medical necessity for the patient. So those kind of cases we need to identify whether we want to include it in our benefit package. The other things would be a much more different kind of payment system. The let's say the chronic cases or like transplant surgery, whether we want to pay it using DRG or we want to pay it using let's say fee for service. You can see from Singapore, if I'm not mistaken, they have moved a bit on not just paying the hospital provider using the RG, but they have three clusters within Singapore. So they're paying within the cluster network using capitation. So it works when the hospital provider and also the clinic provider behave or rights on the incentive by keeping their population within the cluster healthy. So those kind of much more advanced payment system maybe can be used in Singapore, maybe cannot be used in your country or even in Malaysia. The rest would be much more on uh, whether it benefits on the provider, because if you see the advanced treatments or advanced procedures are done at a more tertiary or quaternary hospitals, then you need to understand there will be difference between costing to provide the same services in a much more secondary or even primary level of hospitals.
We have another question from Dr. Shamala Gopal. So it reads, we understand that countries implementing DRG customize the model based on system maturity and market structure. For example, Norway's volume controls and the UK's HRG system. From Malaysia's perspective, what form of DRG customization is being considered, especially in relation to private hospitals?
We talk about adjustment factors. It will be not the same between countries. In for providers, there will be category of hospitals. Public hospitals, we have state major specialists, minor specialists, non-specialists, special medical institutions. Those are cases need to be treated differently. I believe similar with private hospitals. I'm not sure whether we can use number of beds to categorize our private hospitals, but we need to understand the specialty, the services provided for the private hospitals. There are also more quarterly like research within our university hospitals, whether we need to calculate it differently. There are also private wing that being performed from our university hospitals that will be also need to look to differently. I believe in terms of geography in Malaysia, we have East, our Borneo friends, Sabah, Sarawak, and also Labuan will be treated differently than Semenanjung because of a different cost structure or even to the cost item differs even though the product or the item is the same. We also have looked into other countries whether they want to uh, treat differently in terms of, let's say, there are certain initiative or even quality incentive like certification or accreditation that have been achieved by the hospitals. Um, some other countries they use like um the distance between the population and the provider. So the more distance uh, the 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 facilities, then the weightage will be higher. Like Indonesia also, they pay more at the rural hospitals with the same services compared to urban hospitals because they want to incentivize their investors to uh, build more hospitals in rural areas. Those kind of things will be depends on country specific. So like us, we'll be much more, I think, general in terms of what kind of parameter that we want to use. Like I said just now, hospital category, geographical, the specialty that we can use, or even the, let's say, the much more advanced hospital compared to a more basic hospital.
We have a question from Dr. Muhammad Nur Hidayat Marjoki. So, any role of AI integration in the implementation of DRG in Malaysia?
So back in the RG conference in Slovenia, they had we did discuss this whether to use AI in DRG setting. So the AI is help us to actually design the DRG grouper, whether is it homogeneous enough within the grouper, whether the cases or the cost reacts accordingly. And also the AI helps us to identify outliers. There are certain outliers that you cannot see based on the data itself, but it helps because of the variation or the 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 disperse of the data between each other. So those kind of AI features that we can use to help us to identify the data in terms of the outliers or even to recast or regroup the DRG into another grouper. We did discuss this whether AI can help in terms of in hospital settings such as transcribing the um, documentation, whether the patients and the doctors interact, those information can be captured accordingly. So those complete data will be used for a better grouper. And also, I believe if we understand well to calculate the cost for patient level costing requires much more tedious unit cost calculation, not just from top down but bottom up mixed method. So those kind of features, if we have a good dictionary, a good big data, we actually can the AI can learn to help in terms of uh, improving accuracy of our I call it product. So depends on what kind of features that you would like to.
Thank you, Dr. Fauzi. We've reached the top of the hour, but we have a few questions left. Maybe we can try to answer them offline, or maybe if we can have another session, we can add those questions in. I'd like to call on one of our directors at AeHIN, Dr. Alvin Marcelo, to officially close our program.
Thank you, Charisse. Thank you, Dr. Fauzi, for the very insightful sharing from Malaysia. I hope that everyone enjoyed your presentation. I hope you'll be welcome again. You'll grace us with another occasion for an update on DRG in Malaysia. Thank you.
Thank you, Alvin and everyone. Thank you.
Thank you, Dr. Alvin and Dr. Fauzi. Thank you, everyone.
Thank you, Dr. Fauzi. Cha. Good night, everyone.
Thank you.
Thank you. Thank you.
Thank you, Dr. Alvin, Madam Cha, everyone. Have a good night from Malaysia.
Thank you, Doctor. Thank you, everyone. Goodbye.